Many of the people that I see asking for help, their lives have basically been totally destroyed by their addiction.
This is not just an individual problem, it's a huge public health problem.
In Montana, as pharmacists, we're on the front lines of the opiate crisis.
And really what we need to look beyond is the fact that there are real people with real problems, and once you look beyond that disease, you can actually see that individual.
We are the ones that see those prescriptions. We see those patients day to day that are struggling with addiction and abuse.
They may be homeless. They may have absolutely nothing. And they're looking to get their life back.
And it's so much fun to work with the patient who's engaged in their healing process.
Sometimes things take a few years to get here, so we're trying to be prepared and in front of the situation so we don't have some of the same issues that they're seeing on the East Coast.
And all the preconceptions I've ever had about working with people with a substance use disorder have been, I think, disbanded just with a simple smile and a welcome. The stigma essentially is one of the main problems we have with opiate use disorder or any substance use disorder.
Stigma creates a barrier for patients. It's shaming and judgmental.
I think a lot of people have fear of what repercussions they might have if they come forward, and it's different in different populations. We talk about this a lot with women who are pregnant, who are fearful that if they come forward that they'll lose the baby, that the Child Protective Services will take the child away.
And many individuals are afraid to come to care because they're afraid they're going to be either called a junkie, an addict, a drug user, a drug seeker, and we miss on a great opportunity to actually help one of our fellow human beings.
There's also stigma from the provider side, how we as providers respond to patients that are in front of us. We might get very frustrated with a patient's behavior and forget that this is a disease.
MAT has offered an option that helps patients stabilize long enough to be able to learn more about their illness and to move from a life spent chasing drugs to one of sobriety, restoration of family relationships, resumption of work, clearing up legal problems, a lot of the lifestyle problems that go with severe opioid use disorders.
MAT is a miracle right up there with antibiotics.
It saves lives, period.
I've been practicing addiction medicine for over 30 years. Before MAT, patients were miserable. Staffs caring for these patients were miserable. After MAT, people have hope. They can regain their potential.
MAT has absolutely revolutionized the treatment of opioid use disorder. When I first started treating addiction over 20 years ago, we did not have medications here in Montana available for opioid use disorder, and our success rates were terrible. Since we've had medications in the early 2000s, buprenorphine, and then in the late 2000s, methadone, we have had tremendous success in treating opioid use disorder.
It's successful because it basically reestablishes a neurochemical balance in your brain. It almost eliminates all craving, and in addition, people feel normal.
It helps them get control of their disease so we can actually get them the help, the psychological, and help them deal with how to actually get better and actually gives them the time to heal. Without that control, they could be lost.
Every day I see people who have dramatic recoveries from MAT, people who have been hopeless, they don't see that they have any way out, and within a few days, I'll see them a few days after we start the treatment, and it's like seeing a new person. It's like giving them their life back. It is really transforming.
The MPDR is a state database where pharmacies submit their controlled substance prescription information to this database. And then authorized users can access that data electronically, and that helps make decisions about prescribing medications or filling medications.
It's a tool that pharmacists and prescribers can use to ensure that patients are on appropriate treatment.
MPDR is Montana Prescription Drug Registry. It's a place for physicians or anyone they designate to be able to go to and see where our patients may have gotten their last fill of an opioid or what we call a scheduled medicine.
A lot of times patients come in and they're not always sure what medications they're on, and so they might mispronounce the name or they might just know it by the color. By being able to looking at that, we can make sure that we're not putting on a patient on another medication that could increase their risk of having an overdose.
It has probably been the single best tool for physicians that we've had in the past 5 to 10 years in which to better monitor our patients.
And in addition, it can help to detect people who are going to multiple medical providers, getting prescriptions in multiple places. This could be an indicator that someone's starting to run into problems or needs to have some intervention heading towards or in an opioid addiction.
It also helps affect physician behavior. Physicians tend to prescribe less when they know they're being monitored.
The new CDC guidelines for opiate use disorder and the appropriate prescribing of opiates allows us to have a common document and common language where we can interact with prescribers and patients using the same language, again, trying to improve patient outcomes.
And the guidelines are quite clear in terms of when and how it indicates that opioids should be used, and it also indicates limits on the dosage which they feel are appropriate.
A doctor-patient relationship should be individualized to that individual itself. I think they're really good recommendations, but again, they're just recommendations, and the final treatment needs to be individualized for that patient.
The guidelines are very helpful for us to think about what we are doing when we prescribe a medication. And no matter what medication or however treatment, we always look at risk-benefit and what is the benefit that the patient would get from this versus the risk, and have a shared decision-making with the patient on what's the best way to move forward.
Any treatment we do in medicine always has the pros and cons, the risk and benefits. And if we're not talking about the risk involved with starting a medicine that's very dangerous, I think we're not following the true essence of medical ethics, and that's do no harm.
I think it's extremely important. I mean, this is a shared decision-making area where you're going to go with any kind of treatment with a patient and a provider. And so you need to have an understanding, and the patient needs to understand what their risks are of taking these medications and what can be the benefit.
There are a lot of tools that didn't used to be available where you can actually stratify people in terms of the risk of prescribing to them based on their previous history of any addictive disorder, family history, the age at which they first used a drug, other medications they're using.
One of the risk factors is when people combine medications, such as combining an opioid with a benzodiazepine.
One is just the dosing. So if it's a higher dose, you have a higher risk of having an opioid overdose. Another one can be, people can build tolerance up. So if they're used to a higher dose and then stop for a while and then restart at the same dose, they could overdose and even die from the dose that they used to take without much issues.
Other risk factors are underlying medical problems such as lung disease, heart disease.
The other thing that I think that's real important that patients understand is alcohol. And alcohol, along with the opioids, can be a concern.
If we're not monitoring our patients or spending time with them and actually educate them about the medicines, I think that's a big risk factor.
I think the most important thing that I learned is that basically we're all on the same page. We really want to help the citizens of Montana.
I think that my biggest passion or focus in helping with the opiate crisis in Montana is coming up with creative team-based approaches to really help patient outcomes. That's the biggest thing.
The population I'm mostly dealing with right now is patients who have an opioid use disorder and are currently pregnant or just recently postpartum. And so we have a whole team dedicated to their care, getting them through the pregnancy safely, getting their baby delivered safely, trying to reduce neonatal abstinence syndrome, and then also ongoing care to make sure that we get them the help they need to be the parents they want to be without actually going into foster care. So it's a big thing we're trying to accomplish, but we're starting to see some traction and getting success.
It takes a lot of patience to work with this population. It's extremely important to be welcoming and open, non-stigmatizing, non-judgmental, realizing the extensive trauma that this population has been exposed to.
One of the strong things that I think of coming out very positive on this is stigma is decreasing. And I think people are being able to talk a lot more openly about that.
At the center of all of this are people, oftentimes older individuals, veterans who have other needs, and trying to ensure we have the best patient care for those individuals is the most important thing for me.
You start to get back that person that you were always looking for, and this is something we talk about all the time. Stop hating the person, hate the disease.
Here are people that are trying to get better and trying to actually seek to get help, but no one's willing to help them. And when you just open that door and just say, welcome, I'm here to actually assist you getting better, it changes the world. It's been one of my most rewarding areas of medicine I've practiced.
The aspect of opioid use disorder treatment that I'm most excited about is that people do get better, and they can get better. I've seen it, I see it, and I know it's possible.